All right, here we go. So, COVID-19, the knowns, the unknowns, and beyond. Before getting into the juice of the matter, I would like to acknowledge the tremendous collaborative effort of my colleagues, Dr. Saint Germain, Dr. El Khatib, and Dr. Belanger. They've been working extremely hard in order to put this lecture together. I have to admit to all of you that this was probably the most difficult lecture to put together because um, things are moving and changing so fast. The COVID virus, there's a lot of unknowns, and every day we get new data. Things are changing every minute, and it's the same thing with the scientific literature. Uh, the way we prepared this lecture is by doing a PubMed search with obviously the word COVID-19, along with other words such as dentistry, dental, asymptomatic, transmission, etc., etc. Um, we started this preparation about 10 days ago, and we've went through many articles. Every day there's about 20, 30 new 40 articles coming on PubMed. It's astonishing to see how much things are changing. Um, we are starting to understand more things about COVID-19, but there's still lots of unknowns. Um, as things will get to be more known, we will have to continue changing our behavior in order to eradicate the pandemic. Um, but I think that this pandemic has set forward a situation in which both at the medical, dental, economical, at every level, political, there will have to be changes made in the future to, number one, prevent other pandemics, but number two, most importantly, to be ready to react to a pandemic. So uh, I think that we are all aware that a majority of, in different levels of our industries, got caught with their pants down when this COVID hit. Uh, I think that we have to put in question our preparation as a country, especially when it comes to um, having adequate PPEs to protect not only our healthcare workers, but also the population. So in times of chaos, people panic. People react in a very irrational way. This is here a very clear one. Arizona man dies after attempting to take Trump coronavirus cure. So this gentleman heard that chloroquine is a treatment that is used for coronavirus, and although it's not approved yet, it's off label, this gentleman and his wife decided to take a whole whack of chloroquine to make sure he is not susceptible to coronavirus and ended up dying. So we have to be careful as individuals, as also healthcare workers, to educate the population about the knowns and the unknowns, and make sure that people don't follow advice from Mr. Trump on CNN. This is another post that was put in France. The government had to put out this post advising people that uh, cocaine does not cure coronavirus. So imagine that through social media, people can dissipate some of these ideas, and some people follow suit. So uh, again, we have to be careful. There are other areas, there are other people that are taking a different approach to coronavirus. This is Philippine President Rodrigo Duterte, who advised the population that if you don't follow the way that the government had told you to do, we're going to shoot you down. And I don't think that this is politically or ethically right in our country, but different people, different countries, different political systems are using different approaches. Um, let's talk about the coronavirus. So on January 8th, 2020. So that's about 3 months ago. A novel coronavirus, known today as COVID-19, was officially announced by the Chinese Center for Disease Control and Prevention. That's January 2020. The epidemic started in the central part of China, in Wuhan, which is part of the province of Hubei in China. And as you all know, gradually this local outbreak became an epidemic, and then later on a pandemic. Um, about 20 days later, on January 30th, 2020, the World Health Organization announced the outbreak uh, and said that this outbreak has become a public health emergency and an international concern. We know what happened since. So let's dive in a little more in detail in Wuhan how this whole thing started. For those who like to look at the history, we believe that the outbreak started in a local seafood market, and there are some of these seafood markets in China where a lot of merchants are there and they sell either live animals or meat. And it is suggested, and it was sort of shown that the outbreak might have started in a specific seafood market where the pathogen coronavirus was transmitted from animals to humans, and then later on obviously escalating to human transmission. A couple of weeks later, which takes us to February 2020, again the WHO designated the disease COVID-19 for coronavirus disease 2019. So this is the acronym is COVID-19. And for those who read scientific literature, COVID-19 is designated as severe acute respiratory syndrome coronavirus 2, or if you want, SARS-CoV-2. So there's two names for COVID-19 or SARS-CoV-2, which we'll be using in the remaining of this lecture. So again, let's look at how all this started. So as I just told you, this is a zoonotic virus. So it started in Chinese horseshoe bats. This is where this virus is originating from. These bats get their common name from their large nose leaves, which are shaped like horseshoe. There's the facial appearance of these bats, and you can see that they have this large nose leaves, and that's why they're called horseshoe bats. So these bats have infected an intermediate animal, which the Chinese believe is the pangolin. So this is the pangolin. The pangolin are small to medium to large mammals, which are scaly anteaters. Okay, they have these large protective keratin scales that you can see on the slide, which covers their skin, and they seem to be the intermediate between the bats and the humans. These animals are threatened by poaching in China because the scales and the meat of these animals are widely used in Chinese traditional medicine and seem to have some potent healing effects. So these animals are sold. They are maintained live also in these seafood markets, if you want. And it seems that one of the pangolins there was infected by a bat and then obviously transmitted to humans. So when we look schematically at this whole thing, you've got the bat, you've got the pangolin, you've got cross-contamination, and then down to humans, and then we have the spread. So since its origin in mainland China, we all know that the virus has spread worldwide. I'm gonna just stop for a few minutes and jump on the Johns Hopkins website, which all of you can have access to, because what's interesting about their website, it gives you the actual instantaneous count numbers for patients that have been diagnosed or treated for COVID. So I'm gonna go to the website, And I'm gonna just go on. And what you're gonna see is that once we do this, we jump on the website and we can see that right now, there's a total of 1.292564 million people infected worldwide. If you go on the left part of your screen, the United States, and this is not the Olympics, that's not a good spot to be in first, but the United States are first. We hold, you know, uh, pretty much an average Olympic position also, I find, but these are the numbers per country. As you know, this started in China. China was the place where there was the most infected people. As you can see, they were able to control the epidemic locally. Now the Americans are struggling to control all this. So um, I'm gonna turn to Dr. Al-Khatib, the IT expert. How do I go back to? Okay, so now that I've given you a sort of an overview of where this started, how this started, what COVID-19 is, what SARS-CoV-2 is, let's just take a few minutes to try to understand coronaviruses in general. So coronaviruses are a positive single standard RNA virus. Okay, they were first described in 1966 by Tyrrell. And in general, we all know, the medical community knows that these viruses cause the common cold. 20% of yearly common cold is caused by the coronavirus across the world. They are small, spherical, with a coarse shell and surface projections. You can see the surface projections in the slide here. These projections resemble solar coronas. And the reason we call this coronavirus, corona in Latin means crown. So that's where the virus got its name. Members of this family of virus cause, as we all know, respiratory, but also enteric and hepatic diseases, okay? Up to date, there has been 7 human coronaviruses identified worldwide. There are 4 subfamilies: alpha, beta, gamma, and delta. The alpha and beta are mostly found in bats. So bats represent the natural reservoir of these types of coronaviruses. Um, when they sequenced the genome of COVID-19 recently, 96% of the COVID-19 genome RNA is identical to a bat coronavirus called RATG13. So we know where the COVID-19 is coming from. But COVID-19 is also related to other coronaviruses that I'd like to talk to you about. SARS, which we all know, which hit the planet in 2003, and MERS, which I will be talking about in a few minutes. Now, let's start looking at the life cycle of coronavirus. So again, on the top of the slide, COVID-19 is also known as SARS-CoV-2. So before we get into the life cycle, maybe I'd like to take a few minutes to look at other coronaviruses, as I just explained to you. So I'd like to briefly talk about SARS and MERS, which are coronaviruses that caused also epidemics or pandemics a few years back. So I think everyone is familiar with SARS. SARS became an epidemic in 2003. SARS stands for Severe Acute Respiratory Syndrome. There's a picture there. I think this was somewhere in China probably, or even in North America, showing when SARS hit in 2003. SARS is very, very similar to COVID-19. It started also in China in 2003 and spread to other countries and even down to the United States. According to the WHO, a total of 8,098 people worldwide became sick with SARS. That's about it. So we're not talking millions like we see with COVID-19. Of these people, 774 died. So the pandemic, the SARS pandemic in 2003 caused 774 deaths, period. Uh, SARS spread it exactly like COVID-19 from contact between people. The only difference is that SARS was not as lethal. So let's talk about the second one, MERS. MERS is another coronavirus which started more in the Middle East. So the originally MERS started in Saudi Arabia. MERS stands for Middle East Respiratory Syndrome, which is also another coronavirus. The difference between MERS and COVID-19 is MERS was much more lethal. The fatality rate of MERS was much higher, but as we're going to discuss in a few slides, MERS is not a virus that can multiply and spread quickly. So the pandemic or the epidemic did not last long, but the fatality rate was very high. So these coronaviruses, SARS in 2003 and MERS in 2012, were the last two coronaviruses to cause global epidemics, if you want. And today we are struggling with COVID-19, which has become a pandemic. What's interesting when you start to look at the literature and read a lot of articles, and that's what I want to highlight here. This is an article that was published in 2007, which Dr. El-Khatib was able to find and give it to me to present. But what I want to do is I want to highlight the date. So this is 2007. This is 4 years after the outbreak of SARS, right? This is 4 years after the outbreak of SARS. A group of scientists from Hong Kong published this article, and what do they tell us? In yellow there, the presence of a large reservoir of SARS coronaviruses in horseshoe bats, together with the culture of eating exotic animals in southern China, is a time bomb. So I think it's been a while that we know that, you know, we're waiting for something. And I think going forward, there might be some changes locally and globally to prevent such an epidemic. Now, what's interesting also to look at when you start to look at literature is sometimes you turn to intelligent people, much more intelligent than us, or visionaries if you want. And this is an interesting lecture that Bill Gates gave in 2015 in British Columbia. Okay, and listen to Bill Gates.
Today, the greatest risk of global catastrophe doesn't look like this. Instead, it looks like this. If anything kills over 10 million people in the next few decades, it's most likely to be a highly infectious virus rather than a war. Not missiles, but microbes. Now, part of the reason for this is that we've invested a huge amount in nuclear deterrence. But we've actually invested very little in a system to stop an epidemic. We're not ready for the next epidemic.
Interesting. So at this stage, what I want to start to highlight for all of you is a few details about viruses in general. So everyone understands a little bit why local health authorities will, for example, impose self-isolation or distancing. The R naught of a virus describes the rate of transmissibility of the virus, of a disease. Okay, so the R naught basically is the reproduction number of a virus. Each virus is assigned a reproduction number and allows us to know how quickly this virus can spread. So when we look at any virus, we'll have a specific R0. It could be 1, it could be 2, it could be 5, it could be 15. R0 tells us the average number of people who will catch a disease from one contagious person. So If the R is 1, that means each infected person will infect another person. If it's 2, each infected person will infect 2 people around him, etc., etc., etc. When we look at this in terms of numbers, it's interesting because when you start looking at R's, so if somebody's got an R of 1 on the left-hand side, you can see that the infection doesn't spread as much. It spreads and dies out very quickly. As the R gets bigger than 1, you can see that the infection starts to spread and become an epidemic. When you look at measles, for example, it has an R0 of 12 to 18, and SARS that we are dealing with today has an R0 of 2 to 4. So pretty important. I'm going to go into more detail and show you some analogy about all this so you can get a clearer understanding. The next slide will show you a little bit in this slide what you see. In the first column we have the fatality rate. So this is the rate at which people die. So for COVID-19, which is the first line, you can see the fatality rate is 3%. So the mortality rate or fatality rate for this virus is 3%. The reproduction is between 1.4 and 5.5, depending on which article you take. The average is 3. So that means that this virus has a tendency to spread and spread reasonably quickly. If we compare COVID-19, for example, to measles, so if you look at measles, in terms of fatality rate, it's 10 times less fatal, right? 0.3%. But in terms of its reproduction number, measles has such a high reproduction number that it can spread very, very quickly to a large number of people. When you look at H1N1, and we'll be talking about H1N1 in 1918, H1N1, Spanish flu, it's incredible how much it reminds us of COVID-19. It's incredible how much that pandemic reminds us of COVID-19. So to give you a little bit of background about Spanish flu happened in 1918, started in Europe. It remains until today the deadliest pandemic in the history of humankind. 500 million people got infected, 20 to 50 million people died. So the Spanish flu was a very deadly influenza. That's the difference between the Spanish flu and SARS. SARS is a coronavirus. The Spanish flu is an influenza virus. When you start to look at the history of the Spanish flu and the description put forth by doctors and people at the time, in the documents you can see they would say victims were dying within hours or days. Their skin would turn blue and their lungs would fill with fluid that caused them to suffocate. And basically, we know today that when people can't breathe anymore and they get dyspnea and respiratory distress, their oxygen level goes down, they do turn blue and they suffocate. But that's how they described it at the time, right? If you scroll down, there is Ebola virus. Look at the fatality rate of Ebola virus. 70% of people infected with Ebola will die. But as you can see, their reproduction number is a little lower than for other viruses. And this is how we look at the spread of these things. So when we look at the coronavirus, COVID-19, there are specifics about the virus that allows it to infect certain cells. And I'd like to start talking about that. So let's get into the sort of the little things about life cycle of COVID-19. COVID-19 uses a specific receptor to get into our own cells. So let's start by the top here. So remember we talked about the bats being the reservoir, infecting an intermediate host, which we think is the pangolin, and then going down to infecting humans. So this is the triangle that we are living. In the middle of the screen, you have the coronavirus, and the coronavirus has a high affinity to a receptor on cells of our body. The When you look at the outside of the coronavirus, you've got what we call the S protein, and the S glycoprotein binds directly to the ACE2 receptors in our cells. Okay, this S protein has two subunits which help it to attach to our cells, fuse to the membrane, and slide into our cells. So this is the way it works. After the fusion of the virus with our cell membrane, the RNA is injected into our cells. The RNA has all the tools it needs to reproduce itself. So there's replication of the RNA, there's packaging of the virus. Basically, the virus takes over the cell. Okay. And this is like somebody who hijacks your computer. He gets in there as a parasite, he takes over every system, your software, and he can start to do whatever he wants. So, this is what the virus does. It starts to replicate and it starts to shed a significant amount of particles into your body. Okay. When they looked at the affinity between this S protein of the virus and the ACE2 receptor, it looks like this binding capacity is 10 to 20 times fold higher than the one that SARS in 2003 had. So this coronavirus seems to bind very quickly and very efficiently to our cells and cause the problems. So where do we find these receptors, these ACE receptors? Obviously, we find them everywhere in the body, but they are mostly found in the upper lower respiratory tract. We find them actually we find them in salivary glands. So there are different areas where these receptors are found, but where we have a high number of these ACE receptors is in the upper, mostly the lower respiratory cells. Once the virus starts to multiply, what happens then? The viral load in our body starts to go up, and the patient becomes symptomatic by defending against this invasion. And this is where things can go haywire for some patients. So let's talk about viral load, let's talk about viral RNA, and let's talk about the severity of the disease. And when we start talking about all these things, what I can tell you from the literature review we've done is you are threading in very uncharted water. There's a lot of unknowns, okay? You know, some of the questions that we want to know is, does the presence of viral RNA correlate with viral infectivity? What that means is, if you're able to detect viral RNA from a patient, is he still infectious? Is he can he transmit the disease? There are still some unknowns. Testing today, when we look at swab and testing, and I'll show you a picture. This is a swab. And what's interesting about these swabs is when you look at this, people doing the swabs have to be able to insert the swab all the way into the posterior nasopharynx. This is where the swab has to happen. And as you can imagine, it's not easy to do this without people sometimes either coughing, spitting, sneezing. So the people doing these nasopharyngeal swabs are at high risk of infection also, which causes certain stress for some healthcare workers. Once the swab is done, what all the tests today are doing is they're relying on a molecular biology technique called RT-PCR. So RT-PCR means reverse transcriptase polymerase chain reaction technique. What allows us to do is allows us to identify specific type of RNA using a primer, and allows us to multiply to see if we can detect that RNA. So what we are detecting when we are swabbing patient, we are not necessarily detecting live virus. All we know is they have the RNA in their body or not. This is what we are detecting. And it does not give us any indication as to the severity of the virus, where they are in the life cycle, et cetera, et cetera. So as we speak, there are hundreds of tech companies, labs, trying to put together other testing modalities to allow us to move forward. The problem with the technique we use today is that number one, you need to swab the patient, and the way I showed you, right? And the other hurdles that we see is that once you've got this specimen, it needs to be handled appropriately and transported to the lab that is going to test it. The lab needs to have the adequate availability of approved PCR machines to run the test. And finally, the lab has to have trained and licensed technicians to be able to do these tests. So these tests take time and are tedious to do. That is why it is very difficult as we stand today to start testing everybody in the population. It's almost an impossible task to do. And that is why all these other tech companies are trying to develop a quicker way to test for the virus. Um, Here locally in Canada, there are things happening. It's hard for us to know because I think they're happening at a higher level. Spartan Bioscience, based out of Ottawa, is awaiting approval for a point of care RNA testing machine, which supposedly can give us a positive or negative test within 30 minutes. Uh, One thing is clear, before anybody can get these machines, it's going to be a long time because even if they're approved tomorrow, they are fabricated. Before a small dinky clinic like mine in New Brunswick or any clinic or any medical clinic gets one, it's going to be a long time. So this is where the hurdles are. So when it comes to viral RNA and severity of disease, the Chinese have published a lot, and I'm going to show you a little bit what they're putting forward. Again, the Chinese literature is really allowing us to understand a lot of things. When we look at their literature, what they're saying is patient with mild disease or mild illness, 90% of them have negative RNA level after 10 days. So people that don't get sick a lot, they seem to be able to clear the virus quickly. And when we test them 10 days after, there's almost no more RNA in the majority of cases. This is an interesting finding. Number two, patients with severe disease. So patients that are going to go to the hospital, they're going to be ventilated or not, they're very sick. The viral RNA is positive up to 37 days after the start of the symptoms. It does not mean they're infectious, but that means they still have RNA in their body. And that could be linked to the higher viral load that these people had during the disease. And we know they have a higher viral load because these same publications showed us that patients with severe disease have 60 times higher viral load when they are sick. So as you can see from the slide, there's still a lot of uncertainty uh, about the correlation between viral RNA and disease. But I think as the days will go by, as our understanding gets better, we'll be able to hone and multiply our approach to this virus. The other thing I want to talk to you about is asymptomatic patients. This is a really interesting area. And before I start giving you the literature review on asymptomatic patients, I want to define asymptomatic patients very quickly so we all understand. So asymptomatic patients, so patients that have no fever, they have no cough, they have no respiratory symptoms, um, they have no GI symptoms. When you do CT imaging, they could be negative in general, but some of them could be positive, but they're asymptomatic. They're not doing anything. And then when you RT-PCR these people, they are positive. So they've got RNA in their system, meaning they've got the virus, but they're walking around and acting just like you and me. These are called asymptomatic patients. Um, when I started preparing the lecture with my colleagues 10, 12 days ago, we started to look at the scientific literature out of PubMed. And there was not a whole lot of thing about asymptomatic patients. Um, in the last few days, it's incredible how much data has come out of China and Italy showing that actually there are high numbers of asymptomatic patients out there, which we didn't think that they were. And they seem to be able to transmit the disease. So we have to be careful with these asymptomatic patients. And this becomes more crucial as we get into areas where there's community spread. If we look at our little province of New Brunswick, as of yesterday, we're around 100 cases, even though there is ideas of the community spread. Uh, it's not the same as being downtown Montreal today. The community spread is huge down there. and there are a lot of asymptomatic patients walking around, which could potentially infect people. Um, According to a recent article in Science, which came out from again from the Chinese um, data, they think they're saying that there's 4 out of 5 patients infected by COVID-19 that are asymptomatic. 4 out of 5. So until we have more data about the subject, until our healthcare professionals determine the status of infection, and until we get some quick testing modalities, what is really important is 2 things: social distancing and self-isolation. That's why um, these become really, really important. And you have to consider, wherever province you are today, that everyone around you is COVID positive. With this data on asymptomatic patients, everyone is COVID positive until proven otherwise. Okay, so let's continue on with other items on coronavirus. So let's talk about incubation period. Incubation period is defined as the period between the time of exposure to the virus and the appearance of signs or symptoms. Could it be fever, cough? This period here, if you follow the literature and look at all these little different articles, the last one here, Guan, is 7,500 patients. It's a big cohort, and the average is about 4 to 5 days. This is the period it takes between somebody to basically catch the virus and start showing symptoms for the symptomatic patients, right? Um, this study by Guan uh, is the largest, but it showed that the average is 4 days, but there is evidence that could be as long as 14 days. So this is why, out there, the health authorities are advising people to self-isolate for 14 days. Uh, but again, with the asymptomatic patients, this is easy. So if you start showing symptoms, or anybody around you start showing symptoms, it's a 14-day quarantine in order to protect people around you. Let's look at let's turn our attention to the severity of the disease, because you probably, you can see that there are people getting sick. There are people getting very sick. So what do we know about the severity of the illness? Again, a lot of data coming to us is coming out of the Chinese Center for Disease Control and Prevention, right? They've included in their data 44,000 patients, confirmed infections, and out of these, they've given us some data so we can work with. So they're telling us that in their cohort, 81% of patients infected with COVID-1 had mild disease. So 81% had mild disease. Mild disease means they had no or very mild pneumonia and they recovered very well. So these are patients that were not sick a long time. When you look at um, the patients with severe disease, 14% of their patients fell really ill. Okay. And when you talk about severe disease, you talk about dyspnea, hypoxia. There's more than 50% involvement of the lung on imaging. These patients obviously were very sick, required hospitalization, and some of them, if not most of them, required assisted ventilation, if it's invasive or non-invasive. When you look at their percentages for fatality, 5% were in critical state, and about half of those, a little more than half, did not go through it, died. This is where the 3% fatality rate comes in. So these patients in critical state, they were grasping for air, they're fighting for their life. They had severe respiratory failure, shock, and some of them multi-organ dysfunction. So this is where some of these studies come in handy for us, because they allow us to, look at and understand the disease. These patients with severe illnesses, number one, they require a significant amount of energy, of resources from our healthcare workers just to keep them alive. They also require a lot of expertise. And as you can see in these pictures, there is a significant amount of PPEs used to care for these patients. So they tend to overwhelm the existing medical facilities. And this is what most of our health authorities are afraid of. They're not afraid of fighting the disease. They're afraid of getting in a situation like Italy, where the medical system is overwhelmed and unable to react. So, what are some of the factors that make it that some people get really, really sick? These are comorbidities, and I've listed a few for you here. These comorbidities were well identified. What is interesting is that when researchers saw looking at those, the patients that went on to severe disease, about 50% of them had a comorbidity factor, and some of them had more than one comorbidity factor. The most important one was hypertension. It was found in 15%, followed by diabetes in 7.5%, et cetera, et cetera. So these comorbidities are important, and obviously they're alarming for a lot of health care workers. When you think about it, the bulk of our medical dental workforce uh, still has a significant amount of baby boomers, which are in an age that are, number one, more susceptible, but a significant amount of them have comorbidities, and it puts them at a very, very high risk. So when we start looking at the fatality rate of COVID-19, we mentioned it in the beginning, it's about 2 to 4%. We said 3%. SARS, 10%. MERS, 34%. When we look at the population and we say fatality rate that I showed you applies to the average people. So 3% fatality rate for COVID-19 is a average for everyone. Let's look at the fatality rate for the elderly patients. And this is where it gets a little more alarming. When you look at patients that are over the age of 80, their fatality rate with COVID-19 is about 15%. It's not 3%. So patients above the age of 80 that get this disease, 15% of them will die. This is where it's important to protect the elderly. When we take the average between the ages 70 and 79, that risk goes down to 8%, but it's still about 3-4 times higher than the average, right? So it is still really high, and this is the bracket of age that continues to be at a high risk of fatality. Okay, so when it comes to healthcare workers, when it comes to, again, dental, medical, nurses, dental assistants, how do we maneuver around this pandemic? Because when you're in a sea of patients and a sea of people around you, and there is the risk of community spread, there is the idea and the potential for asymptomatic patients to be potentially a reservoir of virus. How do you go about doing all this? How do you screen your patients? How do you protect yourself? How do you protect your family? There's a lot of moving parts, and for those that are in the dental offices, the medical offices, the emergency rooms, they have to be well aware of the risk, and they have to understand how to protect themselves. This past weekend, as we were preparing this lecture with myself and Dr. Belangi, Dr. Kareem, and Dr. Saint Germain, we got a text from Detroit, a young oral surgeon in his last year of specialty, fighting COVID down in Detroit, passed away from COVID-19. He was treating patients. We don't know if he had the proper PPEs. He was 30 some years old. The threat to healthcare professionals is important. And there are data out there that is not completely published. The Italians are saying, what we believe is that, and we'll talk about this a little later, but the severity of the disease seems also to depend on the initial viral load to which we are exposed to. I'll talk about this a little later on in the lecture, but it is important to keep this in mind. So early on in the epidemic, when we started this, you look at the CDC, they had, some of the normal poster out there, advising patients about, you have fever, you have cough, shortness of breath. And these posters are still really important. It's important to have these posters, and it's important to educate the people around there. But what is really, really important is that we continue to evolve and understand that today, um, asymptomatic patients could be also a potential. So how do you screen patients? Um, the best screening tool uh, actually is done remotely. The best screening tool is done remotely. It's to contact your patient. It's to Zoom with them, do Zoom consultation, teleconference. This is the best way to protect yourself. Okay. So we know that in every dental office and every medical office, the administrative assistant is the one who will screen the calls. But if you can deal with most of your emergency using telephone or teleconference, that is the best way to screen your patients and stay away from them. Obviously, the normal questions that you can ask on the phone: do you have any fever? Are you experiencing any sign of cold, runny nose? But also, have been exposed to people around you that have these, symptoms. If you've got a patient that is living in a situation where, his wife is sick, well, guess what? He is considered sick, even though he's not. So these are some of the main questions I'm pretty sure all of you are aware of. Have you traveled anywhere in the last 14 days? These are important. And when you look at close contact, I mentioned close contact in the second paragraph here. What do we mean by close contact? So Kareem, I'm stuck here. I can't move. I got it. So close contact is here. So no, I'm stuck. Just 1 second. Sorry about that. Okay, thank you. So close contact is defined as being within 6 feet of a positive or suspected patient for a prolonged period of time while not wearing PPE. This is what it is. I have a nice illustration to show you later on and make you understand why that distance is important. Let's look at high-risk patients. So obviously, high-risk patients are either COVID positive patients or patients that either have symptoms, have traveled. These patients are high risk, and these patients should not be seen in your dental office. Dr. St. Germain will comment on that later on. These patients should not be seen in the office, and he'll give you some more details. Um, this is how, the Chinese are treating some of the COVID positive patients. And what I can tell you is they've been down this road before us. Their learning curve they're ahead of the learning curve, and they know what they're doing. And actually, they're doing a fantastic job because their numbers are way going down. However, everyone, including people around you, have always be reminded that the best protection is not what these guys are wearing. The best protection for pandemic remains social distancing and self-isolation. This is an interesting poster that was put out there that I was able to find, and this defines a little bit the 6 feet distance between people, and we'll talk about this a little more in detail later on. The reason I put this slide on is what was interesting is that if you look closely on the poster, every individual in this poster has a mask. I don't know if you can notice that. Every individual has a mask, and I know there's a lot of debate about masks and wearing masks and who should wear masks and should people wear masks. Um, I'll give you my view on it. I'm not an infectious disease specialist, and I don't want to pretend to be an infectious disease specialist, but there are some limitations that are important things for people to understand. Number one, in a situation of high risk of infection, if you're surrounded by infected people, if you're working as a healthcare worker, it is important to wear a mask. But in a situation where there's very low risk of infection around you, wearing a mask does not help at all. That's number one. If you are sick and you're coughing and wearing a mask can protect people around you and eliminate some of the droplets going around all around you, so that's not a bad idea. Now, the problem with giving masks to people in our society is that in a lot of cases, a mask will give a false sense of security. This is important. So when people get into this false sense of security, they say, well, self-distancing is not important, I got a mask. Isolation is not important, I got a mask. And this is where they get in trouble. The third thing that is important is that the general population are not trained to put on and remove masks. So sometimes if a mask gets infected and they remove it in the wrong way, they infect their hands and obviously transmit the disease. And the last point that I want to touch on, and this is something that we are experiencing in every medical field, is stock availability. If we have to give a mask to each individual in our little province of New Brunswick, we won't have enough to give everyone. And the people who need it the most, the people at the front lines, won't have any to work with. So let's switch now to some clinical symptoms that people have when they get the virus. So the most common clinical symptom for COVID-19 is fever. This is, depending on which study you look at, 90%, 80 to 90% of people with COVID-19 who started having symptoms, the first symptom was fever. Okay, this is why it is really important to test all patients walking into any dental or medical facility for treatment. You have to test your patients. You have to take their temperature. You have to register their temperature. It is really important to have that. And if they have a temperature, they are sent home directly and they have to call 881 to advise about that. So this is really important. The second most common symptom, if you want, is dry cough. Dry cough is the second most common symptom. And it is also something that happens really early on in the disease. These are followed by sputum production and fatigue. Okay, so again, there are many more symptoms. There's anorexia, there's myalgia, and there's dyspnea. And as we get to dyspnea, that's a lot of times because pneumonia set in and people are getting more sick. So I think as we start on the top part of this screen here, fever, dry cough, and go down, the disease gets a little more difficult to deal with. What is important for all of us to understand is that there are no specific clinical features that can reliably distinguish COVID-19 from any other viral respiratory infection. These symptoms that you see on this page can happen with influenza and any other respiratory infection. So not because we are dealing with COVID-19 that we can turn our head away from influenza. Remember, influenza is also a threat when it comes to infecting medical healthcare professionals and elderly people. When we look at the disease getting worse, pneumonia is the most frequent serious manifestation of the disease. Pneumonia is the most serious manifestation of disease. It's a second stage. And as people go from pneumonia to a more severe state, they fall into what we call ARDS, which is acute respiratory distress syndrome. And this is where the lungs are infiltrated. This is where patients are really, really sick. And a lot of times, as I said, patients will require assisted ventilation. As you can see in this picture, patients are very sick. They've got either invasive or non-invasive assistance of respirators. What happens in that state is that the lung gets infiltrated. There's inflammatory disease that gets into the lung, and there's an acute phase, which a lot of times the patient are able to come out of, and most of them will die. So, so how do people get infected? How do people get infected? And I wanted to take a few minutes to talk about this because I think there's a lot of misconception out there about, how people get infected. When we look at this picture, the reason I put these pictures is that the majority of us like to socialize, like to be happy, like to be around people, and unfortunately, it is not the main way to react or act in these times. Um, COVID-19 spreads by person-to-person contact via respiratory droplets. Okay, so infection will occur when a person touches an infected surface and then touches his mouth, nose, or eyes. Okay, so COVID-19 has to enter through the mouth, nose, or eyes in order to infect the person. There's no other way. If you shake the hands of someone who's infected and you wash your hands, you're not going to get infected. It cannot go through the skin. It has to enter one of the three orifices in the face: the mouth, the nose, or the eyes. The problem with our society is that a lot of us like to touch our face. So this is interesting, uh, because as I was preparing the presentation, I found this article which was published in 2015. So this is interesting because the scientist in Australia decided to follow 26 medical students. He videotaped them, video recorded these students to look at their behavior. And what he found is these medical students touched their face 23 times per hour. They touched their skin 56%, their mouth 33%, their nose 31%, and their eyes 31%. So it is interesting that our own habits make it that we spread this virus. Now, these are habits. We do them instinctively. And this is where people have to understand that the only way for you to catch the virus is to actually take your hands and touch these uh, areas. Now we'll talk about aerosol down the line. There's other ways, but this is what is important when we talk about droplet infection. Okay. So let's get into droplets and aerosol and make, get into more to clarify these things. So droplets in general, they're large particles, over 5 micrometers, which basically will tend to fall to the ground very quickly. Okay. Um, Small droplets, which we're gonna design here, we can designate as aerosols if you want. They're large, they're very small, they're smaller than 5 micrometers, and they can linger in the air up to 3 hours. That's what we can designate as an aerosol. Okay, so when a person coughs, sneezes, laughs, or even talks, some people spit when they talk. In general, they're gonna release those large particles, those droplets, and some small particles, which are either the droplets go on surfaces around them, or they're gonna be in the aerosol for a significant amount of time. So uh, let's look a little bit. I have a little poster to show you, an interesting one. And the important thing to understand is when we talk about aerosols, and you look at this next picture, aerosols are mostly found in dental, ENT, and some of the procedures where we generate them. But if you look at this picture, it's interesting. If you start from the left-hand side, you can see that Ebola in general, when we start to cough and spit, the Ebola will not disperse very far. It's 3 feet. When you look at the coronavirus, you can see it goes up to 6 feet. This is again, the 6 foot that we want between people when we're talking about distancing. This is where it comes from. So you can see that when somebody coughs, there are aerosols that are thrown in the air that can travel up to 6 feet, and some of the droplets will fall closer. Okay. Saliva. So saliva is an area where we work as dentists, obviously, and COVID-19 was detected in self-collected saliva in over 90% of patients. This is again a Chinese study done by Kelvin Wang, and who published it. It's interesting because what he was interested in doing, actually, he was interested in seeing if there's a correlation between the load of virus in the saliva and the one in the nasopharynx. So basically, he wanted to know if he can use saliva as an indicator for viral load. And actually, there was a concordance, 90% concordance between the virus and the saliva and the nasopharynx, which is just fantastic. So maybe in the future, what would be interesting is instead of getting a nasal pharyngeal swab, people can just spit in a little cup so they don't contaminate people around them, and the saliva sample could be sent for analysis. So this is what they're looking at in terms of changes to the swabbing. So let's get into the dentistry. Let's get into more the dental world and see what kind of implications all of these, aerosol droplets have when it comes to dentistry. We have to understand that dentists, OMFS, ENTs, they work in a privileged area where there are, there's a lot of saliva, a lot of virus. So the viral load in which we work is extremely high, and the potential when we do a procedure to create aerosol that contains a high viral load is important. As I said, uh, some of the young professionals dying out there might be dying because the initial viral load they had from the inhaling some of these aerosols was huge. So I think it is important, and the advice we give all the dentists is be very careful, protect yourself with proper PPEs, and we'll talk about that in a few minutes. So before we get into PPEs and some of the recommendations, the guidelines, we are not what we're going to do today is we're not going to, I would say the guidelines follow your dental association. If you're in Ontario, you're in Quebec, you're in Nova Scotia, you have to follow the guidelines of your dental association, not our guidelines. What we're going to give you is what is recommended in the literature. So before we get into PPEs, first question we have to ask is, what is a true emergency, right? What is a true emergency situation? And I've listed them for you. I think all of our dental associations have sent you these. Everybody has these. So orofacial trauma, orofacial infection, prolonged or uncontrolled bleeding, and obviously pain that cannot be managed by antibiotics or painkillers, right? So I would urge you to look at the recommendation of your society and follow those recommendations. This is what's out there in the literature. Now, if somebody has an orofacial trauma, which is an emergency, does he necessarily have to be seen? That is to be determined by the dentist, oral surgeon, medical doctor who's assessing him on the phone initially. So not because it's listed there that it's definitely 100% an emergency. Every case has to be analyzed. And this is why a lot of times we get, either text message or an email, can you see this patient? He needs your help, and we have no information on him. So I think it's important for this is the basics of the emergency, but these things have to be assessed and analyzed. Now, this is a picture from an article, which, and by the way, I have the list of all the articles we use to prepare this lecture. For those who are interested in getting the entire list that we use, we can send that to you. That's not a problem. I'll give you a link at the end. But this is an article which published by, again, a Chinese group. And these are some of the tools that we use on top. As you can see, the tools that we use for dentistry that generate aerosol, right? In oral surgery, we don't use an air water syringe, which you see on the right part of your graph there, because we usually don't use these. So, but dentists like to use this air water, and they do produce a lot of aerosol too. So if we look a little bit more at this article, they have a really nice chart, which I want to sort of go in with you and show it to you. But if we start from the left-hand side of the chart, or an infected patient or an asymptomatic patient or an unknown status patient is receiving dental treatment, using these devices that you see up there, we can generate some aerosol, right? We can generate some aerosol. And when we go and generate aerosols, we know that these aerosols that are smaller than 5 micrometer, they linger in the air for about 3 hours, right? And at the same time that we're working, we are also generating some droplets which are falling on other places. And this is where we can get what we call fomite infection, meaning surface contact infection through susceptible individuals or to healthcare workers. So I think that this is really a nice graph because it really gives us a sense of what goes on in our daily life when it comes to aerosol droplets. So when we're going to talk about PPEs, there are two important things we're going to talk about. We're going to talk about droplet protection. We're going to talk about aerosol protection, and they're completely different. And this is what I want to show you down the line. So when we look at doing a procedure where there is aerosol or droplets and everything settles down, it's been 3 hours, aerosols settle down, the droplets settle down much quicker, and they're on your hard surfaces. Now, how long can how long can the virus stay alive on these surfaces? And most of the studies on this were done using the SARS-CoV, the initial SARS, which is very, very similar to the COVID-19. So when we look at paper, for example, the virus can stay alive up to 24 hours. So if you're bringing your chart with you in the treatment room and an infected person coughs or sneezes, and you take that paper out of the room with you and go fill your chart, the next up to 24 hours, there might be live virus on it, so you can get infected. But when you start getting into other substances like metal, glass, and plastic, it can go up to 9 days. And this is where it's a problem because we know today that human coronavirus, COVID-19, can remain infectious on innate surfaces up to 9 days. So that means that decontamination of your room after you're done is as important as the PPEs you're going to use to do the procedure. Okay, so how do we inactivate the virus? What are the tools that we have to inactivate the virus? There are a variety of biocidal agents out there that have been studied also with for coronavirus. So the same study that looked at, some of the studies that looked at how long coronavirus can stay alive on surfaces also looked at how long, what it takes, to kill the virus, okay? So there are a few studies out there, they're well done. And when you look at inactivation or biocidal agents, the one that comes right away is ethanol 70%. Ethanol 70% destroys the virus in about a minute. These coronavirus have a fatty layer around them, and ethanol really disturbs the fatty layer and kills the virus very quickly. So ethanol 70% is extremely efficient. Sodium hypochlorite 0.1% is extremely good. You've got hydrogen peroxide and povidone iodine 1%. So all of these solutions work very well. You call your pharmacist this afternoon, he'll send you a ton of ethanol 70%. Okay, it's very available out there. If he doesn't have any, it's easy for you to take a bottle of Javex and do your own sodium hypochlorite 0.1% solution. There's tons of Javex out there. So it's easy to equip your clinic with efficient biocidal agents. Now, before this whole thing started, this pandemic, I asked Amber, my assistant here, to give me all the stuff we're using, and we were using Cavi wipes and Clorox. This is what we were using to wipe after each patient. It's interesting because the day this started, I told her, bring me all the wipes we're using, and both these wipes on the label, on that little label on them, coronavirus is present. So these two commercially available wipes are supposed to be biocidal for coronavirus. The problem is, as you know, in terms of availability of these things, it's become a problem. But as I said to you, get a bottle of Javex, dilute it, and use it. It's all you need. Okay. So let's talk quickly about PPEs. Dr. St. Germain is going to go in detail, show you some specifics. That's not my objective. Is not to explain to you PPEs. What I want to talk about, however, is what are the indications to use PPEs, and what are the indications not to use PPEs. Again, what's important to understand is as we go down further the line with this, there's going to be more and more shortages of PPEs, and it is going to become a battle. I was listening to the news a couple of days ago, and I heard that there's two states in the United States. There's two states that are overbidding with companies to who's going to acquire ventilators. So basically, a state had bid to buy ventilators, and it got outbidded by another state, which bought the ventilators. So within the same country, there's a fight. So this is going to happen in our community also if things get worse. So hopefully we can continue to keep the curve flat, and our need for PPEs doesn't jump too high, but be careful about PPEs. Try to save the PPEs for the right indications. So when we look at PPEs in non-aerosol generating procedures, so before I show you these PPEs, non-aerosol generating procedures will include, for example, taking an X-ray. So we do not recommend you take intraoral X-rays because of the saliva and the potential for infection. Take a Panorex or a cone beam scan. All right. So taking an X-ray, doing an exam, removing stitches, doing a very simple extraction, but there's no use of high speed or anything like that. Doing incision drainage of an abscess, doing a temporary filling without using the drill again. All of these are considered non-aerosol generating procedures. And for these procedures, what you need is a level 3 mask, goggles or a face shield, gown or a lab coat, and gloves. That's all you need, right? These are non-aerosol generating procedures. What's going to be important when you do these procedures is not actually the PPEs. What's going to be important is how are you going to disinfect the room after the patient left, which we talked about earlier today, right? So don't forget again that droplets and aerosols react differently, but droplets are as contagious and contain a lot of virus. So cleaning and wiping the entire room is going to be important. It is also important that as a team, you practice how to remove and put on all these PPEs, and Dr. St. Germain will talk about this in a few minutes. So now let's switch to aerosol generating procedures. When we talk about aerosol generating procedures, we're talking about high risk procedure in dentistry and ENT. So in these particular situations, having the proper PPEs becomes really important, right? Number one, you need to have a fitted N95 mask because the aerosol is in the air. And if you're not fitted, you don't have a seal of your mask, when you're going to inhale, you can really inhale a significant amount of aerosol, which contains virus, and infect yourself. So a properly fitted N95 mask is a must. You need goggles and a face shield. This is important. You need a gown or a lab coat with sleeves. Okay. You need a head cover. You need booties. And we recommend double gloves. And Dr. St. Germain will talk about that later on, why this is important. Before you start your procedures, it is important to ask the patient to use a mouth rinse. Again, there's a significant amount of studies done out there on which one are efficient or not. And a lot of the articles that were done that we put our hands on, chlorhexidine has not been shown to be efficient for coronavirus. So a chlorhexidine rinse is not necessarily the best. What we found out there to be extremely good is peroxide 1% mouth rinse. And early on in the pandemic, I called Mr. Ford, Peter Ford here in town, and said, Peter, can you prepare some for us? And he prepared bottles and bottles of peroxide 1% for us. So we get the patients to a rinse for 30 seconds with the mouth rinse. And what's important, as you see here, we ask them to spit in a cup. Because what's going to happen a lot of times, you get them to rinse, and they go to your sink, and they spit everywhere. They got droplets everywhere. And that really creates a nightmare for your assistant to clean and make sure that there's no virus anywhere. So get them to spit in a cup. Make sure your assistant can take the cup with the proper PPEs and suction the saliva out, whatever, but make sure they don't spit everywhere because it's going to be hard for you to clean. When it comes to hand hygiene, this is another important area. And WHO states that hand hygiene includes either cleansing with an alcohol-based hand rub or soap. If you wash your hand with soap, it's not you put the soap in your hand, you clean, and you wash your hands. There has to be a 30, 40 second motion, if taking the soap all the way around your hands and staying there for at least a contact of 30, 40, 50 seconds, even a minute, so the soap works its way and cleanses your hands. It is clear that if you can put your hands on alcohol-based hand rubs, they are very efficient as long as the concentration of alcohol is over 60, 70%. Okay? They are the preferred means. Um, don't forget that cleaning your hands is the best way to prevent any COVID infection. Waiting area of your clinic, there's a couple of things. Number one, the waiting area is not a social area. In general, your waiting area should be completely empty. The way we proceed here and is that we call our patients, they come in, they wait in the car, and when we're ready to see them, the administrative assistant will call them, they'll come up, and then we take them directly to the room. So in general, if you have a waiting room, try to use it the least possible. Before they get to the waiting room, all your patients should have a front door signage talking about COVID, asking them to use, to make sure they don't have any fever. If they do, turn around right away and call 811. The minute they walk into a clinic, there should be a little cart with hand sanitizer, Kleenex at the entrance, in order for them to wipe their hands with the hand sanitizer before they even enter your clinic. And then these patients are met by someone and directly escorted, brought to the room where they have to be seen. If there is for someone to wait in your waiting room, there should be a spatial separation of 2 meters between people. But this is not a situation where your waiting room should be full. I don't think I mean this is a recommendation that is out there, but I don't see any of our clinics having 2, 3, 4, 5 patients waiting in the waiting room at this stage. The first thing you have to do also when patients come into your clinic is to record their temperature. Okay. As we said earlier, one of the first signs of infection with coronavirus is fever. So we ask you to record their fever, and then right away take the thermometer, make sure you clean it with ethanol or any biocidal agent you're using. If you're using an infrared thermometer, still take the time to clean it after every patient. It's really important. As far as ECOS is concerned, East Coast Oral Surgery here, or Oral Surgery Clinic, which we receive referrals locally. Well, we ask the dentist to, number one, talk directly to the oral surgeon to whom he's referring the patient. It's really important. Basically, what we want is we want to know the dental history from the dentist. We want to know the medical history. We want to know, dentists know their patients really well. And we don't want to end up in a situation where the dentist basically sends us a number and a name and says, can you see this patient? We want to be informed. We want to work with the dentist in order to also protect our team and ourselves, right? So we ask that consultation forms are sent in via fax or email. We do not accept text messages of see this or that patient. Legally, they're not good. And also, we want to make sure we have a local track of all these referrals. So we ask the dentist to send us a form, again, explaining the dental history, the medical, and what he wants us to do. And we like to have a phone conversation with them. Finally, if the dentist has got a copy of the most recent X-ray, if he's got a recent Panorex, any recent X-ray, we ask him if it's possible to go into the office and send us a scan of that. Really helps us out and minimizes our need to take our own X-rays. So this is another important thing to do. So at this stage, I'm gonna relay this to Dr. St. Germain, who's gonna talk to you about PPEs, and then I'll come back and give you a final conclusion.
Well, good afternoon, everyone. I'm Eric St. Germain. Don't worry, My part's about 10 minutes. So it's going to be short and sweet. Then we'll have probably a 10-minute question period at the end. Thanks for joining us on this afternoon for this lecture. I hope everyone is safe and healthy. And I will now talk about PPEs, or personal protective equipment, which is definitely the way to stay safe in these crazy times. So for health professionals, what are PPEs? Well, Nash has mentioned them before. We've got the gloves, we've got the mask or respirators, and I'll explain what's the difference between both. We have gowns, we have bonnets or head cap, face shields or goggles, and boot or foot cover. Let's review them, as they can provide a safe barriers against most droplets and aerosols generated from the operative site. Now, this is a quick comparison between the most commonly available masks for healthcare workers. This is from the Crosstech company, which is a company that's well known in Canada and the States. It explains the differences between levels 1, level 2, and level 3 mask, and the famous N95 mask that everybody's talking about now, which is in fact called a respirator. If you look at the chart, this reference sheet, you see ASTM. What that means, it stands for the American Society for Testing of Materials. Now it's an international testing facility. They test basically anything from copper to metal to doors, and anything you can imagine, they test them. And they will publish guidelines for standards and materials for these products. For masks, that are used in the healthcare system, what is tested is the resistance to fluid penetration that you'll see on the chart there. They test the breathability of the mask, the BFE and the PFE. Now, what BFE stands for is for bacterial filtration efficiency, and PFE stands for particle efficiency of the mask using non-living particles between 1.1 and 1 micron. So if you understand properly, the higher the PFE, the better the protection. So level 3 mask will provide better than protection than a level 2 mask, and the level 2 mask will provide a better protection than an level 1 mask. All right, now what we use in our clinics on a daily basis is what we call a surgical mask. There are 3 levels, 1, 2, and 3, that we discussed just a second ago. What they do is they're a physical barrier to splashes, droplets, and spit. The respirators are different. They're more complete. They're a barrier to viruses, bacteria, and aerosols as well. So the N95 mask is in fact a respirator, which will provide protection for viruses. In America, there are 9 types of common respirators. You've got always 2. We've got the N95, N99, and N100, and then you've got the letters, which are N, R, and P. N95 means it filters 95% of airborne particles. N99 will filter 99% of airborne particles, and N100 will filter 99.7% of airborne particles. N means non-resistant to oil, and this is what's used in the health industry. R is resistant to oil, which is something we don't need as health professionals, and P is strongly resistant to oil, which means proof to oil. Now, the N95 respirator. What is an N95 respirator? Well, the N95 mask has been recommended by the Public Health Organization as a tool to reduce the transmission of airborne infectious disease and provide adequate protection for against aerosol generating procedures. The numerical designation 95, as I explained, indicates the ability to filter 95% of particles with the most penetrating size of 0.3 micron. The reliability of the N95 mask will depend on correct usage and fitting. Healthcare workers must go under training on proper usage and pass a fit test to make sure that the mask is doing its job properly. You can see on the mask, if it's a real N95, you'll see what we call an NIOSH symbol, which means it was approved by the National Institute for Occupational Health and Safety, which is part of the CDC, the Center for Disease Control. The fit test. A fit test will make sure that the mask is right for you and that it provides maximum protection. It also verifies that the donning techniques is adequate, creating a proper seal over your face. Nash, Kareem, and I were fitted at the Moncton Hospital. It is a test where you're asked to put on a N95 mask in the correct way, and they expose you to salt particles that are aerosolized in water. You wear the mask with a probe inserted inside. It takes about 15 minutes or so. They have you just breathing normally, breathing heavily, talking, moving your head up, from one side to another and up and down. The machine will then calculate the particles that go through and determine if the fit is right for you. Nash, Kareem, and I were all approved on the same mask. What's interesting to know is that studies have shown that a poor fit can lower the effectiveness of filtration by as much as 65%. So how to wear these respirators correctly? Well, the first step, of course, is to wash your hands. Second step is to select the mask that's right for you. That means the mask that you were fit tested for. Holding the mask with one hand firmly over your face, and then you will use the upper rubber band first and place it on the top of your head. You will take the second rubber band and place it below your ears and the back of your neck. There should not be any crisscrossing of the elastic, sorry. You then mold the metal band to the bridge of your nose using the tip of both hands. Using only one hand can result in an uneven fit and cause leakage of the mask. You finish by doing a self-fitting check by pushing air out of your mouth and seeing if there is any leaks while you breathe in and out. To remove the mask, you need to tilt your head forward, and then you remove using both hands, you grab the bottom strap first, pull it sideways and over your head, and then you use both hands to pull up the upper strap and then over your head and let the mask fall forward into a garbage container. Make sure not to touch the front of the respirator as it is considered contaminated. Now on a lighter side, and this is published by the CDC again, they've done a study about facial hair and filtering face piece respirators. So you see basically they studied all types of facial hairs, and they've got all their respective name, which some of them are pretty funny, like the one for Frank Zappa, the late singer, and the walrus right here. There's even one that's named the toothbrush. I'm sure you can figure out who they found this from. It's one of history's most famous character. But what is to be remembered is that the best of seal can be only obtained with a clean-shaven face, because hair can permit the passage of particles. Now, how to put on your PPEs correctly? There's different ways for donning to put them on, but usually what the CDC recommends is that you put your gown on first, then you put your mask or respirator, the way we explained just a few seconds back, then the goggles, and then you finish by putting your gloves on. And the gloves should cover the cuff of the gown, of course. Now, to remove your personal equipment or the doffing technique, there's two proper ways to do this, and we'll go through both. First, you'll remove your gloves, and remembering that the outside of your gloves is contaminated. So you remove your glove by grasping one glove by the palm area with the other hand. You hold the removed glove in your hand and slide the finger of the ungloved hand under the glove, the wrist of the other glove, and you peel off the glove and you discard it. You should wash your hands immediately, and then you remove your face shield by lifting it by the headband, remembering that the face shield itself is contaminated. You then unfasten your gown, the upper and the lower, touching only, and then you peel it down from your neck towards your body, touching only the inner surface of the gown, remembering that the outside is contaminated. You remove then your N95 mask by the technique we just discussed a few minutes ago, and perform hand hygiene by washing or sanitizing with alcohol-based sanitizer. The second way, and this is more for a gown that would be disposable, you first remove your gowns and gloves at the same time. So the outside of your gown is contaminated, so you grasp it by the mid-body portion and you pull it away from you, folding it upside down. You peel the glove from the inside only to touch the inside of the gown, and if your hands get contaminated, you wash your hands immediately. You then remove your face shield by the headband again, remembering that the outside of the shield is contaminated, so don't touch it. And then you remove your mask the way we described it a minute ago, and then perform hand hygiene. What's important to remember here is that we've done this a couple of times, and it's fairly difficult not to contaminate your hands while you're removing all your equipment. There are some people that would recommend washing your hands between every step of the removal of PPEs. The CDC, they recommend to wash your hands only if your hands get contaminated. For eye protection, there's goggles or face shield. Now, I don't know if you guys can recognize this nice looking fella. This is Dr. Al-Khatib himself, showing it with an N95 mask and our face shields. Face shields are required. They can be single use or reusable. Like Nash was saying, in the context of shortages as we're facing now, a reusable face shield may be a better solution. It should be cleaned between each patient, of course, and you start by cleaning the inside with an alcohol-based wipe, and you clean the outside after. Gloves are, of course, necessary while you're cleaning the face shield. Gowns. Gowns, again, can be single-use or reusable. Again, resources are limited, so reusable gowns are probably the preferred options. What's important here to remember is, like this young fellow showing you, the gloves should cover the cuff. This guy should not have a watch. The watch should be removed before, because it's a source of potential contamination, but the glove should fit over the cuff and cover them completely. The gowns can be safely laundered. There's no problem. They should be put in your washer with maximal temperature allowed by the fabric. For the gloves, regular gloves are okay. We were saying that gloves should completely cover the cuff of the gown, which is sometimes difficult with regular gloves. So what we do once in a while is, instead of having the cuff of the sleeve right on the wrist, we'll put the cuff of the sleeve on the hand, higher on the hand, which makes it easier with regular glove. These are surgical gloves here that you see, and they have longer cuffs. But for regular gloves at the dentist, you could bring the cuff higher on your hand, almost to the beginning of the knuckles. Of course, hand washing prior to putting on gloves and after removing them is mandatory. Sorry about that. The Moncton Hospital, we recommend double gloving, and that's what we recommend for procedures that would generate aerosols. The last PPEs, but not the least, if you're doing something that's like if we're working at the hospital and generating aerosols, we'll wear a surgical cap, and we'll need foot covers also for the procedures. For patient care, close contact that will not generate an aerosol, just like Nash discussed before, a level 3 mask is enough. You need eye protection, of course, either goggles or face shield, and gloves and gown is sufficient. To dispose the PPEs, we just recommend removing them, and you discard them in a garbage, in the trash, as normally you would. Now, this is mostly for people in New Brunswick. Like Nash said, it's important to follow the rules that are enacted by all of our dental societies. But as of Friday, 5 p.m., this is what we received as dentists in New Brunswick. It requires that you consult with your patient over the phone, Skype, Zoom, or other electronic means in order to minimize encounters. It requires that pharmacological treatment be the first option considered, that in-person diagnosis with the dentist can be performed only in last resort. And it also specifies that no aerosol producing procedures can be performed. What this means, means that a COVID positive or suspected patient needs to be referred to a designated treatment facility. It means that if you're doing a procedure that will generate aerosols, they need to be referred to designated treatment facilities, as they should be determined by your own provincial legislation. Again, for New Brunswick, what this means is that in-person treatment by the dentist will not generate aerosols. What we recommend, we looked at these rules enacted by the New Brunswick Dental Society, and we strongly encourage you to do good charting of this, because we don't know what will become in the next coming days. So basically, in New Brunswick, according to the New Brunswick Dental Society, in accordance to the Royal College of Dental Surgeons in Ontario and in Nova Scotia, if an aerosol is to be generated, a fitted N95 mask must be used with all other personal protective equipment. These required PPEs are usually only available at designated treatment facility. The reason behind this is to protect you, your team, protect the patient, but the most important percent to protect is yourself. We also looked at the North Korean Dental Society, and they had a different way of treating future cases. So this is it for me. We thank you all very much. Now Dr. Daniel will come back to conclude, and we'll accept a few questions from the audience. Thank you.
So this is a joke that you could see by Dr. Saint Germain. It's in French, and it says the number of cases in COVID-19 in Korea at 9 o'clock this morning were 3 cases, and their president 9:17 there's 0 cases. He used different methods to clean these cases, but anyways, in conclusion of this webinar, I think that if we summarize very quickly some of the knowns and the unknowns, I think we know that COVID is a serious pandemic. We know it's caused by a coronavirus. We know coronavirus is an airborne disease that can be either inhaled or caught by contact. As I explained in the beginning, there's 3 ways that the virus can enter your body. It cannot go through the skin. It has to be through your mouth, your nose, or your eyes. So hand hygiene is really important. Again, self-distancing, self-isolation. These are really important rules. We know that PPEs are extremely important for healthcare workers, and we know that there will be shortages. So it's important for everyone to really manage their stock and make sure they're using them in an appropriate setting. The other thing we know is that as this pandemic unfolds, there'll be changes. There'll be changes to our guidelines. There'll be changes to the way dentistry will be done. What we don't know is, and we've had a lot of debates with a lot of my colleagues in the last few weeks, is when is it that we're going to be able to go back to our normal practices? And this is a big unknown. There are a lot of unknowns in that area. I think that from my discussions with a lot of people, there are a few things that we have to put in place before we can start doing aerosol generating procedures and all sorts of things. I think obviously a vaccine is one. How far are we from a vaccine? That's not something I can answer. But the other thing is that we need quick testing devices so we can test our patients, get a quick response if they're positive or negative, and be able to deliver the appropriate treatment. So I think these are unknowns, and these are things that will change very quickly in the next few weeks. Finally, I really want to take just 30 seconds to thank, again, my colleagues, Dr. Saint Germain, Dr. El-Khatib, Dr. Boulanger. We worked together on this. I think if I have to credit one guy for doing the most, it would be Dr. El-Khatib. He spent an enormous amount of time on this and was really involved in a lot of things. I'm sort of the front face man here, but he's done a lot of work and he deserves all the credit. So we will have time to take a few questions. This took longer than I thought. We'll have 10 minutes to take questions. You can text your questions in and we will definitely take them.
This is what we see.
Yeah. This one here?
Yeah.
So the question here is from Yoda. Wow, I feel like I'm in Star Wars.
I think it's
If the current, if the current recommendations of isolation and testing relates mostly to symptomatic COVID-infected individuals, should be concerned with the potential transmission by asymptomatic carriers or food supply or pharmaceutical supplies. Yeah, I mean, as I said earlier, we know asymptomatic people shed virus. It is clear. I think that when you go out in the public, again, what's important, if you are within 2 meters of someone, he can sneeze, he can do whatever he wants, you're in that safe distance. Are you going to be able to wear a mask? I don't think they're going to be available. If you come back home, you wash your hands, your groceries, you come in, make sure you remove your groceries and again, wash them. Take the bag, but always wash your hands. So as long as you create that break between contamination of any surface in your mouth and eyes and nose, you're fine. So Mike, can we wear cloth gowns? As far as the recommendations are, it's really unclear. Ideally, we like surgical gowns because they are built to resist to any liquid going through them. But I think in the context, cloth gowns could be a good option. They, however, have to be removed every patient. They have to be washed right away in order to make sure that there's no cross-contamination.
Looks like this with P100 respirators.
So Bill's got a question here. So he's talking about N95 masks, the high cost, and the fact that N95 masks are not available. You're right. N95 mask, fitted N95 masks. Getting fitted, first of all, is extremely difficult now in the province. Number two, once you're fitted, to get the proper mask is not impossible. There's no way. So there are some people that turn to different respirators, and we did that too, which allowed them to work. As long as you have a P100 filter, but if you get a reusable respirator, they still have to be fitted. So you still have to find someone to fit it for you. You cannot use it if you don't get it fitted. So I hope, Bill, that answers your question. Can the slides show?
It's recorded.
Can the slide be made available to those unable to attend? Yes, we have recorded this webinar and it will be available online. So Sophie, question, are 95 masks taken in like home hardware anywhere is okay? So again, you have to understand a N95 mask is as good as the circumstance you use it in. If you're using an N95 mask bought at home hardware to walk around town, it's okay. But if you're using an N95 mask to do an aerosol generating procedure, it's not good. Okay, so why double glove? Double glove is a recommendation from which is out there. We double glove in the OR most times. When you double glove, basically you're creating a two barrier to your hands. Don't forget your hands are what contacts your face in general. So the first layer you remove is your first glove. That's where most of the contamination is, and then you right away minimize a significant amount of contamination. So Heather Vasey, can an N95 mask be disinfected? It's a very good question. It's a very good question. I can tell you, looking at what's happening in other areas like Quebec, where they're running out of supplies, they are reusing some N95 masks, but they have to be fitted again. And they are trying to disinfect them. But again, I'm not an infectious disease specialist. I'm not an N95 mask specialist. So I'll try to get the answer for you, Heather. So for Matt, so the question here, is there a difference between an isolated room and a negative pressure room? A negative pressure room is a room where the system was designed, the HVAC system, to keep everything inside. There's no leakage to the outside. I think that a negative pressure room is mostly used in operating room, and you won't find that in any dental clinic. I think what's important in the dental clinic, if you are doing aerosol generating procedures, is to have a closed door, is that depending on the HVAC system you have, which most have a regular HVAC system, is to let 3 hours for all the aerosol to settle down. If you have a HEPA system, usually it clears the air in 20, 30 minutes. That's different. So turnaround can be different. But you won't find any negative pressure rooms, Matt, anywhere in the province except in hospitals. So what do you think about putting povidone 1% in handpiece water source to prevent contaminated aerosol? So all of these biocidals that I've shown you have been tested in the lab where you've got a virus, you soak it with a biocidal, and you look if it kills it or not, right? So when you are using povidone in your handpiece, don't forget that as you continue to work, the patient has a significant amount of viral load. So virus is always being put out there, and the efficiency of povidone 1% or any other one in this specific clinical context is not known. So that's why it's not recommended to do that. We can make, Bill, we can create a negative pressure in a room. I mean, that's good, but that's not necessarily important or essential, as we know. As I said, I think what's more important than creating a negative pressure room, if you want to invest on your operating room, is to maybe go from a regular HVAC system to a HEPA system, which is a faster system to remove all the aerosols. So it goes from 3 hours to half an hour. So there's a question, does a slow speed generate aerosol? Yes, it does. A slow speed generates aerosol, generates debris flying out of the mouth. So it's not necessarily recommended to use a handpiece, even if it's slow speed. So the question by Jonathan Gallant is, the email from Fredericton Dental Society appears to state that anyone who may be symptomatic will be seen by OMFS, or those who answer negatively will be seen by Brookside. I have not been consulted by the New Brunswick Dental Society, Jonathan, nor has any of the oral surgeon here. We have not been asked to sit down with any committee. So I would like you to ask that question to the president and the boards of the members. I apologize about my answer. Fair to assume that all clinical staff are required recommended PPEs? Absolutely. Your dental assistant has to be fitted for an N95 mask. She has to have the proper PPEs. You have to protect yourself and everybody else. So Dr. Lacroix is asking if this is recorded. It is recorded, and it'll be available to anyone who wants to use it. So question by Dr. Edwards. Number one, Dr. Edwards, periodontist here in Moncton. I want to thank him again for being generous and providing us with some of the PPEs that we're using. It's very generous. What Dr. Edwards wants to know is do we anticipate any guidelines for patient care once this thing goes back to normal? And I think this is a big unknown. I think the different dental societies in each provinces are going to have to work hard, and there will be new guidelines. I think they will be. So it's hard to assume what they're going to be. So Amanda is asking, if she starts to do a simple extraction and it turns to be a surgical extraction, what to do? If you are to go to a surgical extraction and you need to generate aerosol, you don't have proper PPEs, you're exposing yourself and all the staff to a problem. So what we usually recommend is you stop the procedure, you put a couple of stitches if needed, and then you refer the patient to a COVID facility that is equipped to do the procedure surgically. So Julie Nolan is saying that Dr. St. Germain said that PPEs can be thrown in non-biohazard garbage. They can. I think what's important and what I would recommend, what we're doing in the clinic, is to have a bag just for your PPEs. Everything is thrown in, you close it and double bag it. We put it in another bag and seal it, and you can put it in the garbage. We've looked at hospitals and everyone does not recommend any special care, but be careful not to contaminate your staff or anybody else. Are loops considered goggles? No, loops are not considered goggles because they're open all around. So where do we get fitting this done? We got fitted at the Moncton City Hospital. So usually hospitals will provide the facilities to do the fitting of the masks because we provide, facial trauma to the Moncton City Hospital. We were fitted about 2-3 weeks ago, I think. And this is where you have to turn to get fitted. So are there any studies, Pam, show that the effectiveness of UVC light used in the dental profession for disinfection to reduce fomite transmission on surface operatories? The best way to disinfect and reduce fomite transmission is using the biocidals, again, sodium hypochlorite, or any ones that are commercially available. So there are ways on, I got a comment here, there are ways to, on sterilizing N95 masks, but is there ways on, I'll look into it and I'll be able to give you a better answer. So do you think positive pressure will become a standard of care? I don't think so. There's no need for that. So if we are using temperature as screening tool and 80% of carriers are asymptomatic, how does this help? What you're doing is you're basically trying to intercept the ones you know. Obviously, if somebody's asymptomatic, he's asymptomatic. But if you can filter a few patients out of the practice that have temperature, at least you've saved yourself some harm. So Dr. Colley wants to know on centralizing clinics for dental emergencies in the community. I think it's a great idea. I think it takes a lot. It takes a committed board members to sit together with appropriate people in the dental field and try to centralize things. It's not easy because, as I mentioned to you, Dr. Conley, you need to get N95 fitted masks. There needs to be protocols, but I think if you can centralize into one clinic most of the things, you really minimize on the amount of PPEs used. You really minimize on the potential contamination. I think it's a great idea, but it's not an easy task to do. So do we have to wait 3 hours between patients? If you are fitted for a 95 mask and you're doing an aerosol generating procedure, you have to wait 3 hours. That's the time for the aerosol to settle down. If you're doing non-aerosol generating procedure, you do not have to wait 3 hours. So when do you think we would be able to return back to normal operations? It's a big unknown. Hold on to your horses. So can you use electric motors and handpieces such that no aerosol? No, you cannot use a handpiece if it's electrical, air-driven, water-driven without generating aerosol. It's practically impossible. If you're using a high-speed electric without water and you're still drilling on a tooth, there's little pieces flying out, and those are aerosols too. So last question we're going to take. So does community spread essentially mean that we suspect all individuals are infectious? Absolutely. Community spread means the state or the province has declared that there's community spread. So technically speaking, everybody is positive, and that means taking precautions to everyone. And that's why we say if you're doing a procedure, even if it's an asymptomatic patient, but if it's not generating aerosol, still use a level 3 mask. We're not asking you to see these patients without any protection. So, and now with the new data showing that asymptomatic patients are really at a high number, I think it becomes even more crucial to set things in place. Last one, last question. So Abby here is saying that, she consulted with me. I totally agree with you, Abby. You did consult with me and we said we will help. My comment is regarding the New Brunswick Dental Society. The New Brunswick Dental Society has not sat with me, Dr. St. Germain, Dr. El-Khatib, or any one of us to get us involved in helping the community. And that was my answer, and I hope that was clear. We are accepting patients from everyone, but this is an initiative from us, from East Coast Oral Surgery and the surgeons. It's not an initiative from the New Brunswick Dental Society. That was my comment. I hope that clears everything. Thank you. So we're gonna let you guys go. Thank you all again for coming in, and we look forward to your comments.